Hello, everyone. Hopefully, you hear my voice and you're joining on in. Welcome to the AIM Center quarterly webinar titled Practical Tools for Collaborative Care, Brief Behavioral Interventions in Action. I am Monica Harrison, one of the clinical trainers and implementation coaches with the AIM Center. I am joined today by my wonderful AIM Center colleagues, Sarah Barker, who's our Associate Director, and Christy Malmstrom, who is one of our Program Operations Specialists. We here at the AIM Center help support organizations who are implementing the collaborative care model through coaching and clinical training. Since 2017, we have also developed technical expertise in billing and financing collaborative care and have gained a national recognition in this arena. The purpose of the AIM Center is to inspire providers, researchers, and all the decision makers to transform healthcare and improve patient outcomes. We accomplish this by translating and researching evidence-based approaches to behavioral health integration. This call is being recorded and we'll be sending out a link to the recording and the slide deck to everyone who's registered. This webinar format accommodates our large audience today, and you'll see on your Zoom screen that there is a Q&A for question and answer function. We're asking you to use that instead of traditionally using the chat box. So you can enter your questions for the presenters and the panelists at any time, but we'll answer the questions after our panelist has spoken, our presenter has presented, after all of that has concluded. So today, we'd like for you to focus your questions on the experience of these expert presenters and panelists that we'll have today. And if there are more general questions that you have about implementation or financing collaborative care, please bring those questions to our implementation or financing office hours. We host those once a month. You can also check out the FAQs on our website, and Christy is going to be putting the links to both of those in the chat for you now, in case you need to grab those or reference those. So our learning objectives for today, at the end of this session, participants should be able to describe the core principles and evidence base of behavioral activation and problem-solving treatment, identify strategies for delivering behavioral activation and problem-solving treatment in brief, structured formats that fit primary care settings, recognize common challenges and solutions when implementing behavioral activation and problem-solving treatment in real-world collaborative care settings. So those are our three objectives for today. Today's fabulous presenters are Tina Nisbet-Gibbs, Anna Trejo, Annie McGuire, and Patrick Rowie, who will provide a quick introduction of themselves and their organization when they speak. So we're going to start it off with our first person to kind of kick it off for us here is going to be Patrick Rowie.
Thanks, Monica. So my name is Patrick. I'm a clinical psychologist and professor at the University of Washington, and I head up our behavioral interventions at the AIM Center. And next slide. So we think a lot about, in my role at the AIM Center and sort of developing our curriculum and overseeing the training efforts, we think a lot about psychotherapies that we know are effective in kind of traditional, specialty settings, and which of these therapies has been adapted to fit a primary care setting, or could be adapted and fit within primary care in collaborative care kind of service settings. So these are some of the key features that we look at when evaluating these treatments and offer trainings. We make sure that these are evidence-based for diverse populations. And when I say diverse, I mean individuals of different racial and ethnic backgrounds, individuals across the age spectrum, individuals of different educational and financial backgrounds, and urban and rural settings, et cetera. We look for these strategies to also have a big component that's focused on patient engagement. So we know in primary care, when patients aren't always necessarily requesting treatment for mental health kinds of issues, that engaging patients, educating them about these treatment approaches, and engaging them in care and keeping them in mental health care is really important. Um, while specialty psychotherapies have often investigated for 12 to 16 or more sessions in primary care, there's a big focus on kind of condensing that and making sure that there are effective treatments available in briefer versions, 6 to 10 sessions, for example, delivered either weekly or biweekly, lasting anywhere from 20 to 30 minutes each. Another key feature of behavioral treatments that we offer is that they have a structured approach. They're often skill-based, and the clinician has certain format and therapeutic tasks that they want to accomplish within that 20 to 30 minutes. Another consideration is that these treatments should really minimize clinical training time. When people are kind of pulled out of the field and engaged in this training and ongoing support, that we have to really be mindful of the amount of time that we're asking clinicians and behavioral health care managers to take with us. Next slide, please. And so there are a variety of brief behavioral treatments for depression. The most well investigated and with the most support are treatments such as problem solving treatment, behavioral activation, cognitive behavior therapy. And all of these approaches have really solid evidence base and showing that among patients with depression, that these treatments over 6 to 10 sessions really markedly improve depression symptom severity and improve individuals' quality of life. Research also shows that in line with these approaches having sort of a skill-based um, background to them, that when we look at longer-term follow-ups, when acute treatment ends, many patients are maintaining um, the benefits that they've achieved and really empowered to, we call it, be their own therapist and maintain treatment independently on their own without the regular acute phase treatment that a behavioral health care manager provides. And also, these approaches are very much aligned with the treatment preferences that the majority of patients do express. And these are pretty robust findings in different primary care settings and across diverse patient populations as far as their preference for psychosocial or behavioral kind of treatment approach for their depression. And so there are some sort of common elements across all of these behavioral interventions, whether it's problem solving treatment, behavioral activation, cognitive behavioral therapy. Um, and they have certain key priorities. And the first that I mentioned before is sort of this skill acquisition. We're not only helping patients to kind of manage their depressive symptoms, but all of these approaches involve kind of new skills or reinforcing skills that individuals were using before they became depressed. So although there's a big emphasis on empathy and warmth and hearing the patient's story and their priorities, these approaches also add kind of teaching new skills and encouraging patients to apply those skills in the real world in between sessions. And the goal is not to be stress free or help patients solve all of their problems. That's not realistic. But we take priorities that patients identify as far as issues they're struggling with. What are they feeling stuck right now? And we help patients through that and apply these skills. It's also goal focused, and these are not our goals as a care manager or clinician. We help patients kind of get in touch with their priorities and what they want to see change. And there may be, several different goals that they have, ranging from managing their medical conditions to reconnecting with other people, um, diet, exercise, other kind of self-care. And we acknowledge all of those, but we help patients to kind of focus on one goal at a time and a short-term goal, something that they would like to see different about what they're doing or not doing in the next week. So we're really getting down to the behaviors about what they're doing and what they might like to change in the next week. And thirdly, across any behavioral treatment, there's always an emphasis on these between session plans. If we're meeting with patients weekly or biweekly, what can they do in the meantime and how can they practice, try new things out? We don't give them homework assignments, but we help them identify things that they can do and they'd like to try out and practice these new skills. We also encourage that insight and that helping patients become more aware of the connection between things they're doing differently that they're trying out and how that impacts their mood and their other depressive symptoms. And it makes us feel more in control of our moods, and like there's something that we can do that's actually making a big impact on our depressive symptoms. Yeah, next slide. Okay, I'm going to talk about a couple of brief modalities that we offer here at the AIMS Center. And the first one is problem-solving treatment. And this was originally used in the impact study that became the basis for collaborative care. This is a brief evidence-based treatment, anywhere from 6 to 9 sessions. Although in the impact study, it's worth noting that the mean number of sessions that patients attended was only 4, and they still achieved marked benefit. But we talk about this treatment as being a 6 to 9 session treatment. Very effective across diverse settings and implementation settings at reducing individual symptoms of depression and anxiety and improving quality of life and functioning. Sessions are only 30 minutes, not the traditional 50-minute psychotherapy session. And the emphasis, getting back to skill-based approaches, is to help patients learn these problem-solving skills, and with our support, manage their symptoms, but in between visits and after acute phase treatment is completed, to independently manage symptoms over time. And very briefly, sort of the process overview, it takes a patient identified problem, one at a time, so we can kind of focus on one issue and illustrate the problem solving process. And using this structured process where we teach patients about the different steps associated with successful problem solving, we help them as a care manager to come up with an action plan, a homework assignment that they give themselves that they would like to use to try out to address this problem and see if it solves the problem or the first part of a problem. And it's not only getting success at solving certain problems, again, skill-based, so teaching the patient this 7-step process so they can apply this to new problems that come up in their lives. Going to switch on to behavioral activation, which is another very powerful evidence-based behavioral intervention that we train to at the AIMS Center. And there's some overlap with problem solving, but it's a distinct intervention. And behavioral activation has 3 main goals. And the first is for the individual with depression or anxiety symptoms to help them increase what we refer to as adaptive activities. These are things that are important to people, that are consistent with their values, that they may have stopped doing because of their depression, feeling low, feeling no motivation, and being sapped of energy. And we help individuals kind of get in touch with things that they'd like to start doing a little bit more of, to be mood boosters, to feel accomplished and satisfied with how they're spending their days, how they're spending their weeks. And this is not just a pleasurable activity like, having ice cream, for example, but we help patients to kind of tune into things that give them a sense of both mastery and pleasure. So things that make them feel accomplished, but that they enjoy doing at the same time. And as these mood boosters build up, this is a very powerful treatment for depression. Another goal of BA is to decrease activities that maintain depressive symptoms. So this could be things like inactivity, not doing, not engaging in activities, perhaps rumination, kind of getting stuck in one's thoughts. So we come up with strategies to kind of interrupt that cycle. And lastly, last goal is to problem solve barriers to rewarding things. And we help patients to kind of, when they think of an action plan or something they'd like to do, to kind of think of any barrier or obstacle that could come up and how they want to handle that and what are their plan Bs. And if they weren't successful, then the next time we meet with them, we kind of talk through what got in the way that we didn't predict and how, if this is still important to you, how do we get around that? So that's a really brief description of our two super powerful behavioral strategies that we train to at Ames. And in the last couple of slides, I want to talk about common challenges that we see. And the biggest one is lack of patient engagement and care. It could be at the very beginning, we identify elevated depression and we offer different treatments and patients say thanks, but no thanks. Or it could be they start care with us, but then they don't come back or they don't kind of engage in the between session activities. So the next couple of slides are some of the things that we think about to address this big challenge in care. And the first is to think about collaborative care and the different ways that we use psychosocial or behavioral interventions. And everywhere from identification of need, we screen using the PHQ, for example, and we determine the diagnoses. I'm going to get to number two here. Number three is what we've been talking about, these specific evidence-based interventions like problem-solving treatment or behavioral activation. Number four is for people with more chronic or treatment-resistant kinds of conditions, referral out. But I want to hone in on this second kind of area that we can use psychosocial interventions to engage patients in particular. So psychoeducation, I'm going to talk about that in the next couple of slides, what that means. But also we have motivational interviewing and shared decision making that we think of as ways to engage patients in any kind of mental health treatment that they would be interested in following through, whether that be a behavioral treatment or antidepressant medication, for example. And just a couple of words about psychoeducation. It's helpful to think of psychoeducation as a conversation where before we don't lecture patients, we don't kind of stand up and teach them. It is a conversation where we first learn from them their experiences, for example, about depression and anxiety, their beliefs about what it involves, how they can best manage it, and what treatment means. And then we use that to engage in a conversation about what we know from the evidence base about what depression and anxiety are and the different treatment options. And the next slide, part of that is providing information on symptoms and how depression affects our functioning and quality of life, medical terms that we use. What do we know about what causes depression and what can be effective at treating depression? Or what are some common things that people think might work, but the evidence doesn't really show that? And so we make space for this back and forth questions and from patients so that we can really get on the same page about common mental health kinds of conditions. And we don't do this just in meeting number one. It's an ongoing kind of strategy that we come back to again and again with patients. And briefly, a second solution to that problem that we identified about lack of patient engagement in mental health care are what we really commonly see quite a bit with patients undergoing treatment for depression. And that could be an emphasis on reviewing homework or any kind of action plans that they decided to follow through. So we help, regardless of the approach, whether it's problem solving or behavioral activation, we help in the next meeting patients to kind of process how that went. Um, how did it go with this, action plan that you created that was important for you in the past week? And were you satisfied with your efforts? Was that a mood booster like you predicted it might be? And then making those connections between those efforts and improvement in mood and other depressive symptoms, as well as rewarding activities. And it doesn't always go according to plan, but that's part of the process with homework review. We identify what got in the way that we didn't predict. Could be lack of buy-in to this kind of action plan or idea. Patients forgetting can be really common, or inertia associated with depression, making them feel that this is too challenging. I planned something that was a little bit too big. And so part of our training involves, okay, how do we work with patients with each of those barriers, and how do we move forward and kind of re-engage them in the problem solving process. And that might be it for me. Thanks, everybody.
It definitely does not always go to plan. You're right about that, Patrick. Thanks for setting that context for us, especially for our discussion today. So I want to have some dialogue with our other panelists around those concepts that Patrick was just talking about and how they kind of translate in the field, like boots on the ground, as my military family would say. So, could each of you provide background on yourself and your experience in integrated care, particularly with collaborative care and the organization you work for, starting with Tina?
Hello, Tina Nisby Gibbs here. I am a licensed mental health counselor here in the state of Washington. I work for Kaiser Permanente, Washington, where I'm a program manager. And related to collaborative care, I am working on, I have been going through the train the trainer process through the AIM Center so I can learn all the different parts, components of the collaborative care model and deliver it to individuals who are part of the collaborative care team. And I have had a caseload myself. So I have been in the role of a care manager as well as a clinical implementation team leader.
I'm sure you won't be alone. I'm sure there are many who are listening who are wearing dual hats, Tina. Anna, you want to go next?
Sure. My name is Anna Trejo. I am a licensed mental health counselor, and I work as a behavioral health counselor lead for Sanitas Medical Center in their behavioral health program. It is called Be Well, and I am in Florida. I also started out as a care manager. I've had that full caseload and then transition to be a lead and now support 10 to 15 counselors and do some trainings. And I'm happy to be part of this panel today. Thank you for having me.
Absolutely. We're happy to have you, Anna. Annie, you want to go next?
Hi, everyone. My name is Annie McGuire, and I'm a clinical trainer and practice coach here at the AIM Center. But prior to working with the AIM Center, I was in the role of the behavioral health care manager for over a decade at a few different primary care settings. So, and then also worked in implementation, but while having that dual role of always having a caseload and working as a BHCM. So, yeah, definitely excited to talk about these interventions today and hopefully answer some of your questions.
I'm excited about it. So, for those of you who are attending and listening to us, if you have specific questions, definitely drop them into the Q&A. We'll get to those a little later. But you know me, I've crafted some questions for you all based on things that I've heard, seen come up, just came back from a conference. So some of the buzz that I've heard people talking about. And so I've crafted some questions based on that and what I knew Patrick would be talking about this morning or this afternoon, depending on where you're listening, what time it is when you're listening to us. So one of the questions that I had was what training or supervision approaches kind of could best prepare clinicians to be able to deliver behavior activation or problem solving treatment. Like you all have kind of gone through this process of being in that behavioral health care manager role, kind of now taking on the lead, wearing both hats. And so, just your thoughts on what training or type of supervision approaches someone might need to be able to utilize BA or PST with their collaborative care patients. Tina, want to go first?
Yes, the lifelong learner here. I will gladly start this conversation off. I want to just highlight the fact that one of the things that I appreciate while going through this process with the training model is like the didactic instruction, the skill building practice, the ongoing consultation, and, just guidelines for carefully monitoring um, outcomes for the patients. As far as training approaches, basically a lot of our training started with, and I thought it was a good idea, it started with the online training that AIMS offers. It was for all members of the team, so the care managers, the primary care providers, the psychiatric consultants. So that was one thing that I felt that was very beneficial for all of us. And then there was like what I considered the orientation phase. So after the training, we had like a life skills training. So it was like delivering care as a team. So since these interventions are provided in like a team-based approach, training that covers like the roles and responsibilities of each member and the workflows for the interventions that we're providing for the specific interventions, as Patrick pointed out, there's the fundamentals of the skills. So for behavior activation, training on activity scheduling, monitoring the mood and balancing, the pleasurable activities as well as mastery. And for PST, I'm just going to use acronyms. Just the multi-system approach, to 7 steps to be exact. Defining the problem, brainstorming solution, creating the action plan, and do not forget to evaluate the outcomes. Training that focuses on clinical skill development, learning how to adapt the interventions for a wide range of patients. In a brief format, consisting of, I know there was a lot of like what we consider role play or case calls, so we can review and refine some of our skills. As far as supervision is concerned, as well as for training, it's not a one and done, it's ongoing all the time.
Mhm.
Hopefully everybody's familiar with the systematic caseload review. Um, that's one of the places where you can get the supervision where the care manager meets with the psychiatric consultant. And so you're reviewing caseloads, you're getting guidance on maybe treatment plans to include maybe adapting some of the interventions you're using, like behavior activation or problem solving treatment. Um, consultation, consultation and coaching. AIM Center provides like the hours for support and ongoing support. And then sometimes, locally for our team in Washington, we have where we have our leads. We have 2 leads. We have a team of at least 20 individuals in care managers positions. And so the leads are available to provide consultation or coaching on an as needed basis. Well, not as needed, but within those set hours. And then we also have weekly team meetings where the whole team comes together and we get consultation and case reviews at that time. Another thing, a supervision strategy that we implement, and it was something that we were doing before actually spreading collaborative care throughout our region, is the measurement-based treatment to target. So that's a supervision strategy where you're tracking the progress or the outcomes of the patient, and you're reviewing it in the systematic case or reviewed. And since it's part of our standard work practice here in KP Washington, we have a standard work practice where in each visit, we capture what we call the mental health progress monitoring tool, and it includes the PHQ-9 for depression and the GAD for anxiety in each visit. I can speak forever, but I'm just going to put one more point. One more point. You know me, Monica, mouth, mouth, mouth. One thing that is very important as far as training and supervision is that you use that and that it can be used to inform your efforts for quality improvement measures, efforts. You know, you take the metrics from the measurement-based treatment to target and see if you need to refine some processes or other ways to enhance patient outcomes. So that's it for me.
Okay. No, I heard a lot of things in there. I definitely heard a lot of
Yeah.
things in there. But thinking about for training and supervision for the clinicians that will be providing the brief interventions, I heard the importance of first off receiving training,
Hmm.
didactic, live in person, whatever that needs to be. And then the importance of having some ongoing, that it can't just be one and done. So
Right.
whether that's individuals decide to do what you all did at Kaiser Permanente, where you have leads who are then providing some ongoing support, whether you contract out or in-house provide some technical assistance. I heard that in there. One of the things I don't think many people think about that I heard you talk about was utilizing the systematic caseload review time, because even though most individuals think about the psychiatric consultant providing input on medications, they could also provide input on brief interventions.
Right.
If there maybe is a different brief intervention strategy or something of that nature that would be good to try, it's a great opportunity to utilize your psych consultant during systematic caseload review time to have some of that conversation and get some additional feedback and have another person that they could go to for that. So thank you for that.
I want to point out that our psychiatric consultant said that it's a learning process for them as well, a learning
Mm,
opportunity, you know, to keep abreast of like some interventions and different ways to use it. So, yes.
gotcha.
Hmm.
Thank you.
Uh-huh.
Anna, I'm wondering if you can highlight or talk about, as a behavioral health care manager, how you or individuals on your team introduce the brief intervention, whether that's behavioral activation or PST, how you introduce that to patients in a way that feels accessible and not overwhelming. Because some of this can be a lot, right? Like when you really think about it, some of them have multiple steps, some have forms, right? Like just all of the things. How do you introduce it to your patients so that it's not so overwhelming?
Absolutely. So one of the things that I learned as a care manager was not to introduce any of these interventions during my first meeting. So my first meeting is the assessment, right? That's where I get to know who I'm going to be working with, the client, providing a safe space, letting them know that we are going to be working together. So I use the word we a lot with clients. We're going to be working on X, Y, and Z based off of what they're telling me, right? And I ask them first, I focus more on the why. Why are we here? And what is it that the client wants to achieve? So during that first visit, I get to know them and the presenting problem, right? The first thing that they say. We typically figure out 3, 4 sessions later that the presenting problem is probably not the actual problem, right?
As
That's why
Patrick said, it's never simple,
it's
right?
never. So at the beginning, I just get to know them, figure out the why. And when I do introduce it, finally, the second session, what I do is I ask the client, where do they want to begin? So our program is targeting symptoms of depression and anxiety. So I ask, where do you want to begin? Do you want to begin talking about depression or talking about anxiety so that we can have a split, right? Because sometimes it's too much to talk about. We only have 30 minutes. And then in that first visit, which we call the active phase, I get to know where that client wants to go. And then at that point, if it's depression, I'll introduce, okay, so what is depression and talk about what is depression, give a little bit of education, and then go into that part where we say, do nothing, feel worse, do something, feel better. So that's how I introduce behavioral activation. A lot of times I stay away from the technical words, the clinical words, like we're gonna do behavior activation, because half the time they're gonna be like, what is that, right? So I just try to be more conversational and introduce it in a simple way where they feel comfortable, like, okay, yes, I want to feel better. Okay, tell me more about how you would like to feel, what's going on, and get an idea of what they're doing for fun. That's definitely one of my biggest questions. What do you do for fun during my assessment? And that's typically where we need to focus, right? I don't know. I haven't done anything. They haven't even done anything pleasurable in a really long time. They're so busy. So a lot of times that becomes part of the behavioral activation. Okay, what do you like to do? So in that sense, I get a feeling of what would they like to do through the things that they haven't done in a while. And that's how I introduce the interventions. And then by the end of the day, they're doing the behavioral activation. And I don't go into the technicalities of how, the intervention is XYZ. I don't find that fruitful for my practice and for me.
Gotcha. So
Mhm.
being able to make sure that your patients from the start are going to feel comfortable and not feel too overwhelmed, and you'll slowly kind of ease them in, not first session, but more second session, ease them into some of the concept of like the examples you were given of behavioral activation with pleasurable
Exactly.
activities and things like that.
And then lo
Okay.
and behold, they start doing things, and we're in the behavioral activation phase, and they start simple. They decide what it is that they want to work on. They decide what they want to do first. And it's really them, but I always say we.
Gotcha. Letting the
Mhm.
patient lead, right? Because it
Yes,
is their session. And
absolutely.
letting them lead to get that high level of buy-in. Okay,
Absolutely.
okay. Well, I hear already some changes in language, right, that we use with our patient population, to make it not be as overwhelming. I'm wondering if any of you, as behavioral health care managers, how you address cultural or contextual differences when needing to tailor behavioral activation or problem solving treatment to the patient population in front of you. Annie, you want to go first since I
Sure.
allowed Tina and
Sure.
them to go first? Okay.
Yeah, sure. I can go first. I think for BA, definitely really assisting the patient with choosing meaningful and culturally relevant activities that align with their values and also their available resources. And then when I think about PST, I try to focus on and making sure that the problems and the solutions that we're exploring are realistic within that patient's cultural and environmental context. I think that's really important. So, a solution that involves having the patient reach out to a specialist, like a trauma therapist, for example, may not be acceptable in a culture with a lot of mental health stigma. So that might not be realistic. So just making sure that those the problems and solutions are realistic within that cultural context, I think is helpful. Another thinking about in PST how you're brainstorming solutions. There was some PST research done among Chinese older adults who tended to perceive a professional who asked them for solutions as being less
Mhm.
competent. So many of these patients responded really well to the clinician providing them with a handful of really good options for meeting their goal, but then the patient would weigh the pros and cons, and then they would select the solution based on the pros and cons that they worked through. So that seemed to work well. So yeah, just considering flexibility and based on who's sitting in front of you.
Which makes sense to me that you didn't change the core, like even in that example, right? Like you didn't change the core foundation of the steps, but
Mhm.
just in terms of did a little bit more facilitation with the brainstorming
Yeah.
section, right? Because of that. So considering some of those cultural nuances and the importance of that.
Mhm.
Tina, I saw you come off of mute. Were you going to add?
Yeah, I was just thinking about sometimes those of us who are from the mainstream culture and we think more like in individual terms and we set the problem or define the problem as like something that the individual needs to address, and in their culture they're more like collective and they're more about community. So seeing it as a problem that can be addressed or approached by the family or the community, and as well as including those individuals in the part of the problem solving efforts. And then I was also thinking about changing um, Anna when she said something, as well as Annie. Something about, like changing the style or your language with
Mm,
delivering
yeah.
maybe the information. I know the AIM Center, and I found some other tools about like individuals who have low literacy or limited English proficiency. You have to kind of change things where you might have worksheets, you might have pictures, visual,
Hmm.
aids or something along those lines, and then worksheets in different languages. If you're working with the youth, you might want to do more apps or what something along those lines, but just different ways to adapt to the culture or with processes that are more familiar and personable to the patient.
The importance of us being as adaptable as we are trying to
There
get
you
our
go.
patients to be, right? Like it
Right.
goes both ways from that standpoint. So one of the things that I know is important, just as a part of collaborative care, we're doing measurement-based treatment, right? So it's not just with medications. We do need to be looking at also how things are going with the brief interventions that patients are taking part in. And I don't think as a behavioral health group, we've always thought about that, but it is important for us to make sure that our interventions are working, that they work for the patient. So I've already heard some of you guys talk about like the patient choice and like the patient voice being in there and making some choices. I'm wondering how you measure success, whether clinically or from an operational standpoint, when you are using brief interventions. How are you measuring that success? Anna, what you think?
Right. So clinically speaking, we use the PHQ-9 and the GAD-7 to measure improvement in symptoms,
Okay.
right? The first thing that we do during the first visit is collect the baseline, and we're trying to um, focus on at least 50% less, right, of the symptoms from their baseline scores. So that would be one measure, clinically speaking. The second, and doing those measures every 30 days to get an idea of if there is improvement or if they're not, or just they're stagnant or if they need additional support, right? And then the second thing we do clinically would be the self-report, which is when the client comes in and they say, "Oh, I'm feeling a lot more energy, I'm sleeping better, I
Mhm.
feel that I'm able to do more things on a day-to-day basis, so improve daily functioning." They're finding meaningful activities pleasurable again. So that's self-report. And then with PST specifically, where you get to see that they come back to a session and they've identified a problem, they've made a plan, they've
Yeah.
taken actionable steps, and they come back and they tell you, "Oh, I've been doing this and it's working." And so this is outside of session. So they're independently able to engage in the behavioral activation on their own and the problem solving on their own, and reducing symptoms of both depression and anxiety. And
Which
then
is
the third,
perfect.
right, exactly, which is the goal, right? That's the
Yeah.
whole reason why they come to us in the first place. So the last thing that predicts um, improvement in symptoms is engagement. When we see clients coming consistently to their sessions and they show up and you can tell that they are engaged and they're taking notes. I love the ones that are taking notes. I want to know what they're writing. So it's like, oh, they're taking notes. Okay, great. And they ask you to repeat something. What did you say? Okay, and then I love that because that just makes me feel like, okay, this is working, right? So
Yeah.
clinically speaking, that's how we measure success. Now, operationally, we also measure success, and we do that a bit different. We have the AIMS caseload tracker. We track the caseload. We can do reports on there, the caseload metrics, caseload statistics. We also look at the percentage of clients' scores, their PHQ-9s and their GADs. We can see the improvements there if they're being done on a 30-day basis. We look at the percentage of cases that are brought up to psychiatric consultation when they get to that mark, right? That 10 to 12-week mark. If we see that they're not improving, we should present those cases. Typically, there's a recommendation for a medication. And then when we see the adherence of those medications, we can also measure success because typically clients feel better with the behavioral intervention and the component of the medications. And then we also see operationally that there are less frequent visits to the PCP, those diminish, less hospitalizations, less hospital visits, even for panic attacks or anxiety. And so operationally, behind the scenes, right, that's
Yeah.
how we measure
So
success.
seeing a lot of ways that that patient engagement, what Patrick mentioned, was one of the common
Mhm.
challenges, shows up in the things that you could do to try to keep the patient engaged and how that helps across the system, not just about them showing up for your virtual or in-person visit, but there's some benefit across the system there. So I
Mhm.
definitely want us to have time to get to some of the questions in the Q&A. But one of the things, I know we talked a lot about BA and PST, but one of the things that I'm wondering if each of you could share what other modalities that you might use with patients outside of BA and PST. Tina, you want to go first? Just what I'm just wondering by name, what others you might use.
Motivational interviewing, mindfulness-based interventions.
Okay.
Those are some of the
Annie,
main
what
ones.
about you?
Yeah, definitely weaving motivational interviewing into all things. And then CBT, cognitive behavioral therapy for insomnia, I used quite a bit. And
Mhm.
then distress tolerance skills. I used a lot of distress tolerance skills, very approachable for patients and clinicians and very doable in brief visits.
Gotcha. Anna, what about you? What other modalities?
Same.
Okay.
Same
You're like,
one.
check, 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 check,
Yes.
check, check mark.
I
Yeah.
may ask a question, maybe like a specific question, like the miracle question if somebody's like
Mm,
really stuck because they can't give me any answers. So I may ask that or maybe some DBT,
okay.
very brief, like I use the wise mind with
Gotcha.
with clients, different things like that. But mostly everything that Tina and Annie said. Yes.
Gotcha. I love that miracle question. That's one of the benefit that's solution focused. For those of you out there going, miracle question, that's a part of solution focus, which is another brief modality. Okay, so let me be the first to thank you all for giving of your time. It's always really valuable to hear from those who are in the field, stepping up to do the work and share their learning and experience of like what's working and what's not, right? Want to now toss it over to Sarah, who's my colleague, so that she could read from some of the questions that were submitted so that presenters and panelists can respond.
Great. Thanks so much, Monica, and thanks so much, panel. We've gotten a lot of great questions in. As a reminder, for general implementation questions, we really recommend everyone come to our office hours. There's been a lot of great implementation type questions, so maybe we can drop that into the chat. But a question for the panel, how do clinicians work with resistance to these more structured approaches? You know, patients who've engaged with traditional psychotherapy believe this traditional approach is the one that's the most helpful for them. I know you talked a little bit about resistance. Maybe you just expand about on that a little bit.
What do you think, Anna, about the patient who's like, this is not working out for me. It's like, this ain't gonna do it.
Absolutely. So motivational interview comes in this one, right? So we want to roll with the resistance, as MI says. So we want to acknowledge the resistance and normalize the resistance. We want to lean into it and ask questions, explore the meaning of the resistance. Tell me more about what makes this feel like, if they say it's so simple, for example, because most of the time clients will be like, that's just way too easy. I could just do that, right? And so that just sounds way too easy, or I don't think that's going to help. And so I asked them, tell me more about what makes you feel this is so simple, or what makes you feel this won't help, and what are more helpful things you think we can do, right? Instead of the idea that came up, well, maybe that's not gonna work. Okay, tell me what has worked for you in the past, and maybe reminding them of the time when things were good, that they felt good, and seeing what else we can do. So I don't like to box in the person of like, this is what we're going to do. So I like to find, okay, let's find something that we can both agree on, right? That this could be a good fit for you. And then reframing a lot of times the intervention, right? Like giving a little bit of education on the intervention, like saying many of these evidence-based interventions are simple by design because they have been proven to work, and this is why we use them. And maybe giving some examples that may be helpful, some examples of how it has worked in the past, and then just letting them know that if it doesn't work, we can always change it. We're not stuck with this one idea. We can always adjust and change if it doesn't feel helpful. Then I like to let the client know, please tell me if something's not working. Let me know if you come back to a session and really be free to say, okay, this didn't work at all. And I like that. I appreciate that, because we do have some clients that they want to please us, right? So they're like, yeah, yeah, everything's good. And you're thinking, they didn't do it, did they? So making that space safe, I think, works with resistance really well.
Great, thank you.
Mhm.
How about, does the panel have experience with pushback from psychiatric consultants as to the interventions that you're using with patients, or maybe the psychiatric consultants saying they're really more comfortable trained to focus on medications? How do you kind of work with that with your psychiatric consultant around these brief interventions?
Nobody has had pushback. Annie, I
I
know
haven't
you've
I
had
wouldn't
some
say I've had a
pushback.
ton of pushback, but I think there's definitely times where I've had to kind of train the psychiatric consultant, especially when I was using the psychiatric consultant for my systematic caseload review, but then had just onboarded several new clinicians that were newer to practice, and they needed definitely more psychoeducation about meds, but also about brief behavioral intervention. So um, I made sure to incorporate into my case presentations always what I was doing behaviorally and around brief interventions with the patient. And then I would ask if they had any thoughts, or if this isn't working out, any ideas for where to go next as far as brief interventions. So I would start to pose those questions and then specifically ask for added support around that for clinicians that maybe were newer to the field and needed that. Um, I think doing some kind of brief in-service or training around just what it is helpful. Not every psych consultant is familiar with PST or behavioral activation, or so I think making sure they know what it is, because it was so helpful when I felt stuck with a patient, and then a psych consultant was able to say, "This sounds like PST could be a good fit for this individual." Um, so yeah, but they need to know what that is and when to kind of recommend it. So yeah, those would be my main things. I haven't experienced like extreme pushback, but there are ones who focus more on meds, and just to normalize incorporating all things more holistic.
How about, and maybe this is a question too for Patrick, around kind of evidence base for applying behavioral activation with patients to advance self-management goals. This question also is asking about using like BA with pregnant patients. So maybe talking a little bit about using BA with pregnant patients' perinatal populations.
Yeah, so well, the first part I was going to say that, BA is a really flexible approach and can help, meet the needs of people who are experiencing depression or anxiety or, having a tough time, meeting self-care needs. So I think it's really about, it's very tailored to the issues that an individual patient is going through. And as Annie mentioned, it does sort of focus on kind of somebody's values and what's important to them rather than us as a clinician kind of deciding for them what they should be doing. Um, and Regarding perinatal populations, BA has been really kind of investigated quite a bit with this population and adapted, and so there's a lot of really positive outcomes with around pregnant patients and their ability to use and benefit from behavioral activation as well. Any other clinical trainer, please feel free to chime in on that too.
I think that
Gotcha.
individuals
Okay. Oh, go ahead.
oftentimes find it surprising how well BA could work with lots of specialty populations. I think it is one of those things, I say you're teaching the patient a skill, whether it's BA or PST, right? But even when I think about BA, like there's some benefit in it for many populations of patients of teaching them that skill set of being able to identify activities and get a rhythm with doing those activities. It ends up to me just being, I always say it's some extra to put in your toolkit of strategies to try and to use because no one strategy works for everything. So I use a lot of analogies when I'm talking with my patients about your toolbox, and you have a toolbox that has different tools because different things you're trying to fix need different tools. Sometimes you need the flathead screwdriver. Sometimes you need, right? I don't know all of them, so I'm not going to pretend like I do, but it takes different things. And so this is a part of building up your toolkit for that purpose. Tina, go ahead. I think I cut you off. I didn't mean to cut you off.
No, it was basically along the same lines that you were stating. And one of my first individuals on my caseload was a pregnant patient. So that's one of the populations that we serve within our program. So it was interesting. And you're right, it was something else to add to her toolkit. And it was a very successful case. So for her, on her terms, as she
Gotcha.
defines success. But yeah.
Gotcha.
Do,
So of
do we have time?
course,
Do we
we
have time
don't
for
have time.
anybody?
We never have enough time. Like we could sit here all day and talk to you all about all things related to collaborative care. Just want to re-emphasize, as Sarah did, that any of your questions that were more about implementation, finance, or even if you're a behavioral health care manager and you have specific questions, we have office hours tailored to each of those things. Our panelists will stay on and answer in text format any of your questions that may have been more tailored to them. So if you have a moment to hang on, they will answer you. I don't want you to feel left out. And then for those of you that are thinking about, okay, now what's next? We do have some resources that are here available for you in these last couple of slides. FAST training, which stands for First Approach Skills Training, is now something that is being offered through the AIM Center for those of you who are providing services to collaborative care services to the pediatric population. Know that this is available for you. Check it out if it's something you think you even might slightly be interested in. So read up on it and know it's out there and it exists. We also have links for you to some articles that were published around brief interventions, as well as training that you may be interested in regarding brief interventions that is available to you. And as you all know, we do these quarterly webinars 4 times a year, so once a quarter. Here are our dates for next year. We don't have our topics quite outlined yet, but hold these dates so nobody schedules patients during these times for you. They don't schedule you in a meeting that you're available. So hold these dates for 2026. These are when the quarterly webinars will take place. And of course, we ask you to join us on LinkedIn. If you haven't joined us already, we are on LinkedIn. So please join us on LinkedIn. That is where we publish up and coming things that we have going on, engage with others throughout the collaborative care field. So please feel free to do that. And I know that Christy already dropped the link to evaluate and provide feedback for the webinar. So we're looking for topics for 2026. So drop them in, fill out the form. And as always, 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 we thank you for coming to our webinar for today and hope you have an amazing Rockstar Day. Panelists, if you see any questions there that you feel like you can answer, feel free to do so while some folks are still on.
I have to leave for
Okay,
another training, but thank
absolutely.
you. Thank you.
Thanks, Tina.
All right.